Well, welcome everybody to the Department of Medicine Grand Rounds for today, October the 19th. We have a special event today, and to take the reins, I'm going to turn it over to Dr. Erin Kim from the Division of Hospital Medicine. Erin?
Hey, everybody. I'm Erin Kim. I'm a hospitalist over at VA, and I'm in charge of the division's visitor professor task force. So it's my pleasure to introduce Lenny Feldman. So Dr. Feldman's an associate professor at Johns Hopkins. He's a founder and program director of their MedPeds Urban Health Residency. He's an expert in many things, but perioperative care, resident medical education, high value care, and kind of more pertinent to today's talk. So he's the Journal of Hospital Medicine's editor in the Choosing Wisely campaigns, things we do for no reason. It's my pleasure to have him here as our visiting professor and to introduce him. So thank you, Dr. Feldman.
Erin, thank you so much for that kind introduction. I really appreciate it. I am so sad that I am not there in person. My institution has been pretty conservative about travel during COVID, except yesterday they decided to stop our ban on travel yesterday. So I am still here in Baltimore, regardless, and really excited to be with you guys today. So thank you for inviting me. And it's really nice to see so many friends that I've met through the Society of Hospital Medicine over the years. So thank you. We will be talking about things we do for no reason. I don't have any disclosures. And other than, as Erin mentioned, I am the co-editor and founder for the Things We Do for No Reason series in the Journal of Hospital Medicine. It has been really quite an honor to have been involved in the creation of this column. I put my email on there that you guys can email if you have any ideas for the Things We Do for No Reason series. You may be surprised, but there is not a short supply of ideas. They are coming in all the time. We were just told by Samir Shah, who's the editor of the journal, that we have enough Things We Do for No Reason to do them monthly until the end of 2022, already approved and through the peer review system. So needless to say, we're always looking for more, but there's quite a queue at the moment, but contact me. So we're going to talk about why providing high value care is difficult, name some low value practices today, and plot a path towards high value care. And this is the latest data. I don't think we have 2020 data quite yet. That usually comes out a year or two after. But our national healthcare expenditures are now up to 3.8 trillion. When I first started giving these talks at the Society of Hospital Medicine in 2012, we were at 2.5 trillion. So in 7 years, we've added on 3.8 trillion, 1.3 trillion to get us now up to 3.8 trillion. It's a lot of money that we spend every year for our health expenditures. It's almost 18% of the gross domestic product. It grew 4.6% from the year before. When I started giving these talks, we were under $10,000 on average per person in the United States. We're now almost up to $12,000 on average per person in the United States in terms of healthcare expenditures. Medicare keeps growing. It's up to 800 billion. Medicaid is at 600 billion. And of course, private insurance is the largest of all of these at $1.2 trillion. All of them continue to grow. Out-of-pocket spending, one of the areas that worries me the most, is now $400 billion. And we know of many patients who have very high deductible insurance plans where they are spending a lot of money out of pocket before their insurance actually kicks in. And I think often dictates whether they will get care or not. And then hospital spending, where I spend most of my time, it's about a third of the healthcare, national healthcare expenditures at $1.2 trillion. And we know that while outpatient clinic visits are the largest number of bills that patients receive, the biggest share of the actual bills come from the emergency department, hospitalizations, and radiology exams. That's where the real expense starts to pile up. And so that's when as a hospitalist, I tend to focus on the hospitalization side of this and what we can be doing in the hospital that might be able to decrease money. And we know that patients with these high deductibles, they will make decisions. I've heard patients talk about how they are sitting outside of the emergency department with their child with an asthma exacerbation, trying to see if that child is going to turn around with some albuterol before they bring them into the emergency department, because they know that the expense is going to be just so massive if they actually set foot into the emergency department. And we know that medical bills are one of the leading causes of bankruptcy of patients in the United States. So oftentimes people will define value as the numerator of patient care, quality, safety, experiences, and outcomes. And on the denominator side, the personal and financial costs for the patient. And I think one of the things that we don't do a very good job of when we're talking about value is we tend to just look at the value right at the moment and not the downstream value that we know there is going to be. This was a study from 2019 that was a national survey that had about a 50% response rate, asking physicians if they've had issues with incidental findings in care that then caused cascades of care afterwards, right? Oftentimes the big expense is not the tests that we do right now, but all the tests that it leads to. And in it, I think all of us would agree with this study. We can all think of times over the last year where we've done a test that's led to more new non-invasive tests that have led to more new invasive tests. And that's all because of incidental findings that were found on the test that cause physician harm and that cause patient harm. We can all think of times that's happened to us, I think many times over the last year. Don Berwick and Andrew Hackbarth in 2012 had a paper in JAMA. This was when Don Berwick was still with IHI and before he ran, I think, the Centers for Medicaid and Medicare, that they had come up with this study looking at the amount of waste in the healthcare system. And as I mentioned, in 2012, the national healthcare expenditures were about 2.5 trillion then as compared to 3.8 trillion now. And Don Berwick and Andrew Hackbarth were estimating that on the high side, the total amount of waste in our system was $1.26 trillion, which, I'm doing my math correctly, is just about 50% or just over 50% of the national healthcare expenditures at that time. They were estimating could be wasteful. On the low end, it was 558 million. That's still basically 25% of our healthcare system that is wasted, or our healthcare expenditures that are wasted, right? It's a lot of money that certainly could be used in a lot of other ways if we were not wasting it with our national healthcare expenditures. And one of the ways that we know that there is all this waste and in our national healthcare expenditures is that we have wide variations in the way that physicians practice and how much they spend on their patients. This was a study that came out in 2017 that looked at Part B Medicare spending for patients who were hospitalized. They looked at sort of on the level of the physician, and each physician that was looked at had to have more than 10 inpatients in the year of 2011 to 2012 to be able to get in the study. And then they averaged how much in Part B spending they were spending on those Medicare patients. And you can see that there was quite a range, a lot of variability in how much the physicians were spending on each of their Medicare patients. And, you could make the argument, well, if the people who spent more, if the physicians who spent more on average had better outcomes, then that's probably okay. But the problem was when you look at this graph, it seems to indicate, right, if down at the way it would look is if the patients who had more money spent on them would have a lower mortality, they would all be down here. And the patients who had less money spent on them would have higher mortalities. They'd all be up here. And there'd be this nice line going down, connecting them. Instead, what you see is this very straight line that tells us that the more the physician spent did not improve mortality, because this is adjusted 30-day mortality rate, did not improve mortality at all. And so you certainly do not want to have this physician up here as your doc, where they were spending the most money and having over a 40% mortality rate. And you kind of want to be the doctor down here who is spending the least on their patients and having really great mortality outcomes. So no clear evidence that spending more money on patients, at least Medicare Part B money, meant better outcomes for those patients. And we try to get at why do we have this waste in medicine? And I talked about this earlier with the group, the hospitalists, when we were talking about high value care just a few minutes ago. This is a study that came out of the University of Pennsylvania in 2016, where they looked at internal medicine residents there and general surgery residents there, had them complete a survey about whether they had done any unnecessary routine labs. They had a pretty good response rate, about over 50% in the internal medicine and general surgery residents. And 83% of the residents said, yes, I've seen unnecessary routine labs ordered, or I've actually ordered unnecessary routine labs. And then they asked them, well, how often does that happen? And 50% of them said every day it happens. That's a lot. And then they asked them, why is this happening? And the vast majority said it is practice habit. 90% said it is practice habit. I am trained to order repeating daily labs every day. Another big percent of them said, about 86%, it's a lack of cost transparency. Another 75% said it's concerned that the attending will ask for the data and I won't have that data. And another 67% said, well, I just don't see anybody role modeling cost-conscious care. And so there are many reasons that people come up with as to why, and this was a study from 2008, a systematic review, as to why there's waste in diagnosis and treatment in medicine. And to me, it all, I think, comes down to the most part to one main thing, and that is that bottom one of learned behavior. Yes, patients will ask you for an MRI when they have back pain that they don't need, and that can be really hard to say no. Yes, there are economic incentives of self-referral that get people to do things. Yes, there's defensive medicine, but in the end, I think so much of this is about learned behavior. And right, we go to residency for a reason. We go to fellowship for a reason. We want to learn how to practice as an internist and residency, and then whatever fellowship we're doing, we want to learn how to practice that fellowship. And we have attendings who practice in a certain way, and we follow their lead because they're teaching us. And then we practice exactly like that, as the data seems to indicate, for another 10 to 15 years after we finish residency. So it ends up being that learned behaviors, I think, is a really big part of why we have the wasteful behaviors that we tend to do. So how do I have some data that is true? Well, one of them is this study that came out in 2014. And this was from the American Board of Internal Medicine board exam for first-time test takers of the board. So recent grads taking the boards for the first time. They have two different scales, subscales on there, an appropriately conservative management subscale and an appropriately aggressive management subscale. Now, the conservative subscale means that the question will have a stem in it where the answer you're supposed to pick is something like watchful waiting or not doing anything. It's not that you get another test. The aggressive management subscale is the answer to the question is, oh yeah, I'm supposed to do another thing. I'm supposed to get an imaging study done, or I'm supposed to call the surgeon, or whatever it might be. I'm supposed to be aggressive about the management of the care. So when they look at the conservative management subscale, they then correlated that with where folks finished where they did their residency, where these grads had done their residency, and is that residency a place of high value care or not? And they had data to show that residents who had graduated from a program that was more high value care did better on these conservative subscale questions than those residents who came from areas of the country with lower value care. And that was true regardless of how the residency in general, the residency graduates in general did on the ABIM certifying exam. That it really mattered what they were being taught as to whether they could get the right answer about whether they should be a conservative or aggressive when it came to the management of patients. And that also plays out in real life after you graduate. This was a study that looked at primary care physicians and their spending patterns based on where they did their residency and then started to practice as a primary care physician. And they found that if a resident came from an area of the country that was, again, more high value in their residency experience, they spent less on their Medicare patients than residents who came from a hospital referring region that spent more in general on their patients during residency. And that difference could be up to $1,000 per Medicare patient. Again, based on where you did your training as to whether you learned how to be high value care during your residency or whether you did not. These are learned behaviors that you then take out with you, whether you're on doing a board exam or whether you are out in practice as a primary care physician. And I am sure the same thing is true whether you are finishing a fellowship and then going out to practice as a subspecialist. So what are some of the ways that we can intervene then and try to teach high value care or try to make sure that high value care happens in our settings? This is a study from 2017, a systematic review that looked at many different interventions aimed at reducing the use of low value healthcare services. Things like cost sharing with patients, that again comes back to the high deductible kind of thing. Patient education, hey, when you have low back pain, you don't need an MRI, so don't ask for it. Provider report cards that patients could see, hey, this physician is more high value, you should go see them. Pay for performance for the physicians or ensure restrictions. And then the things that most of us as physicians start to do, the provider feedback, clinician education, or clinical decision support. And today, for the next hour, I am certainly just doing the clinical education, which we know is the least effective of all the ways of trying to get people to practice high value care. So sorry to be doing that to you all, but I don't have much of a choice. I can't start doing any pay for performance for anybody at the middle of grand rounds. So one of these different issues brought to mind and what started then was all of these issues brought up different practices that we are involved in that do not improve patient care and still cost money, things that we ended up calling the things we do for no reason. And I started giving these talks at the Society of Hospital Medicine in 2012, and then we started the column in the Journal Hospital Medicine of Things We Do for No Reason in 2015. We're over 60 different topics now that we've covered in Things We Do for No Reason, right? These are all one-offs. We look at one practice at a time, but we have no illusions that this is somehow fixing all of our waste in our system. But they are hopefully things that then we can pass on to residents and help to create a culture of high value care by pointing out the things that we do that are not high value. So I'm going to hit on a bunch of different topics right now and focus on a few different issues. So In the radiologic study area, there's a bunch of things we do for no reason. We do ultrasounds for AKIs in the first couple of days that a patient comes in, not giving them a chance to show that whether their AKI is going to get better, not necessarily just doing the bladder scan if we're worried about the patient having an obstruction at the level of the urethra. We do ultrasounds of abdomens after already having an abdominal CT that almost never shows you the acute cause of the abdominal pain if the abdominal CT did not. People still do carotid Dopplers for syncope, although they almost never show you a reason for why a patient would have had syncope. We still do Dopplers in patients with cellulitis, wondering if there is a DVT under that cellulitis when that almost is never the case. And we still very regularly get echocardiograms for patients with pulmonary emboli, no matter what their clinical situation is. But I'm going to get into a different kind of radiologic study that I think we don't do enough of. And we're going to do a case scenario. We have a 74-year-old woman who's admitted to your service because she cannot walk due to worsening knee pain. She has a history of lung disease and has been receiving prednisone 20 milligrams for years, along with NSAIDs for pain. And this was a patient that I saw here at Johns Hopkins. She reports chest pain that occurs with exercise and sometimes rest. The substernal chest pain is associated with shortness of breath, but no radiation, nausea, or diaphoresis. And it is relieved by sitting. So she had that kind of chest pain, but then she also had chest pain at rest that's associated with a sour taste in her mouth. And so she ended up getting admitted to my service because of this chest pain and also her issues with walking. She had a Framingham risk when you actually calculated of less than 10%. And she had an EKG that showed no dynamic changes, no ST depressions, and negative troponins here at Hopkins. And the resident said, hey, we should get an outpatient functional stress test on her with that chest pain to see if she's having any obstructive coronary disease. So then what's the appropriate response to that? Is it A, let's just up her atorvastatin, add an aspirin, and add some antianginals? Is it B, I agree with your recommendation, an outpatient functional stress test it is? Is it C, hey, why not do a coronary CTA here? Is it D, I think it's time to consult cardiology for that cardiac cath? Or E, how is it that she is my only patient who is not on a PPI, which I believe she actually was my only patient who was not on a PPI at the time. So what I'm going to argue is the things we do for no reason here are often getting functional cardiac stress tests when we are worried about having obstructive coronary disease rather than getting a coronary CTA. We avoid why should we avoid the functional stress test? One is the operational characteristics. I just don't think they're that good at telling us who has obstructive coronary disease. And it's not just obstructive disease that we're looking for in the end. So here's a study from 2010 that looked at all the cardiac catheterizations done from 2004 to 2008 in the US with patients with no known coronary artery disease. These were all elective caths. So these are not patients who've come in with acute coronary syndrome, NSTEMIs, STEMIs. These were patients who had basically stable coronary artery disease that they wanted to know, do you have any obstructive disease? 84% of those patients had had a non-invasive stress test done first, and they ended up defining obstructive disease on the cardiac cath as 50% of the left main or greater than 70% of an epicardial vessel. And what you'll see is even if you have a negative stress test and you had a low risk of Framingham risk, you still had a 10% chance of having coronary artery disease. If you had a negative stress test and a high risk of a high Framingham risk of greater than 20%, you had a 55% chance of having obstructive coronary disease, even with that negative stress test, right? It didn't tell us when it was negative that those patients were not going to have coronary artery disease. And even the lowest risk of those patients still had a 10% risk of having obstructive coronary artery disease. How about on the positive side, even when you had a positive test, still only 20% of the patients in the low risk category ended up having obstructive disease with a positive test. And even if you were high risk and you had a positive test, only 70% ended up having obstructive coronary disease. The non-invasive stress test really didn't do a very good job at all of telling you who was going to have obstructive coronary disease. And you compare that over here to patients who had no test done, no stress test done, and they still had basically the same risk of having obstructive coronary disease as those who they got a non-invasive stress test in first. So my contention is the operational characteristics at baseline of these tests are not great, even for finding obstructive coronary disease. Obviously, this does not include patients who had a non-invasive stress test and then no cardiac cath. So it certainly biases the study. The endpoint here is only obstructive disease, not whether they have any coronary artery disease. And there were probably some patients in this study who had coronary CTAs, although from 2004 to 2008, I think that's a very, very, very small number, if any. So why do I think we should use coronary CTAs instead of the functional stress test? I think one, it helps with the diagnosis of both obstructive disease and atherosclerotic disease. It will change management, both in terms of medications and patients who are appropriate for CABG. And those management changes seem to improve health. They may increase medication adherence and give us some clinical prognostication. So what do I base that on? A couple different studies. The first is this PROMISE study, which was a US-based study, 9,000 patients who had stable chest pain with intermediate risk factors for obstructive coronary disease. They were randomized to a functional stress test versus coronary CTA with, I think, a primary endpoint that many of us would find reasonable of death, MI, or unstable angina. And the mean follow-up was 26 months. They ended up defining what was found on anatomic testing or functional testing as either severe, moderate, mild, or normal. Basically, severe meant that you had multi-vessel disease or significant left main disease or left anterior descending greater than 70%. Moderate meant you had basically one vessel, one epicardial vessel that was diseased above 70%. Mild meant you didn't have any obstructive disease, but you had disease. And normal meant we think that your coronary artery disease, your coronary arteries are normal. So the severe disease group, not as interesting. Pretty similar between your functional group, which is here, the anatomic, this is the coronary CTA group, sorry, here on the left, your functional group on the right. You'll see that in both the coronary CTA and the functional, they found about the same amount of severe disease, and those patients had about the same event rate. Where you start to see a difference is in the mild group. So the functional stress testing found very few patients in the mild group. The anatomic stress testing found almost over half the patients were in the mild coronary artery disease group, which meant that there were many fewer normals in the coronary CTA group as compared to the functional stress testing group, where almost everybody, 80%, ended up being normal. And the reason that's important is because whether you were mild or normal had a very different event rate between those two groups of those events that we said were important: death, MI, unstable angina, of 3% versus less than 1%. In the functional stress test group, you can't tell the difference between the mild patients and the normal patients. They all have the same event rate. It doesn't tell you who's normal and who's not. They were both fine at finding severe disease, and moderate was about the same in both group two. But mild and normal, very different. And if you just look at cardiovascular death or MI, you could see in the coronary CTA group, again, mild meant a 1.6% chance of that event. Normal meant a 0.5% chance. That's pretty different. But there was no difference in the functional group between mild and normal. And that, I think, leads us right into the Scott Hart study that came out in Lancet in 2015, which was a UK-based study where patients were referred to a center for suspected stable coronary artery disease. This was 4,000 patients randomized to standard care versus standard care plus a coronary CTA. They followed them for 3 to 7 years and had another important endpoint combined of death from coronary artery disease or MI. And what you'll see is they asked them at first, the cardiologists who saw the patients, do you think they have coronary artery disease right from the outset? And in both groups, it was about 10%. Then the 6 weeks went by, and during that 6 weeks, in the group that had standard of care plus coronary CTA, that group had the CTA done. If they were just getting standard of care, they had whatever standard of care they were going to get done. And 6 weeks later, now the cardiologist said, oh, after I have that coronary CTA, actually, when I thought that only 10% had coronary artery disease, it's actually 23%. And those in the standard group, it didn't change at all. It also meant a difference in who didn't have coronary artery disease. The cardiologist at first said about 7% in both groups didn't have coronary artery disease. After that coronary CTA, now 15% don't have coronary artery disease. And in the standard group, it really didn't change at all. Same thing is true for when you talk about the diagnosis of angina. That went up in the coronary CTA group. That didn't change in the standard group. And those who didn't have it went up in the coronary CTA group. I'm pretty sure you don't actually have angina, when that didn't change at all in the standard, right? It really made a difference in classifying patients. And then if we classify our patients differently as, yes, you have coronary disease, or no, you don't, then you have a difference in management. And so the patients who had standard care plus coronary CTA had a lot more medications started or stopped as compared to the standard group that had many few medicines started or stopped. And hopefully then, if you are starting and stopping medications, that will make a difference in patients' ultimate outcome. And it looks like it did. The primary endpoint at 4.8 years of death from coronary heart disease or MI happened more often in the standard of care group at 3.9% as compared to the group that got standard of care plus the coronary CTA. And it wasn't because they ended up doing more invasive cardiac catheterizations. That was the same in both groups, or more revascularizations. My theory is that this is all about the medications that people were receiving. They were put on the right meds. They got their aspirin, they got statins, they got the right meds, they got their blood pressure under control because they had coronary artery disease. Maybe they got their diabetes more aggressively treated because they had coronary, whatever it was, people managed them differently, and that led to improved outcomes with a number needed to treat of 62.5 for coronary heart disease and non-fatal MI, which is a really pretty good number needed to treat. And just for non-fatal MI alone, it was 71. And there wasn't any subgroup that did better by getting standard of care versus getting the coronary CTA. It reminds us that obstructive disease is not the be-all, end-all, that it's really important to find that patients have atherosclerosis, that then we are going to be more aggressive about their care, because we know that up to 2/3 of future cardiovascular events occur at locations where previously no obstructive lesion was found, right? It's happening at these hot lesions, not necessarily the obstructive lesions. And then this is the final study that I'll talk about. This was a 600-person study where they looked at patients with acute chest pain but had a normal ECG and troponin. They again randomized them to either get a coronary CTA or exercise treadmill on a bike or a nuclear study. And they looked at a primary endpoint of a couple years out of cardiac death, MI, hospitalization for unstable angina, late symptom-driven revascularizations, and readmission for chest pain. It went down by 5% in the patients who had the coronary CTA. as compared to the patients who had the stress test. And I think again shows us that if you are found to have non-obstructive coronary disease, we then treat those patients more aggressively, and it makes a difference in their outcomes. So our mantra should be diagnose atherosclerosis, prevent events by starting the right meds, send the appropriate patients to CABG, but avoid, of course, PCI that doesn't need to happen. And reminding ourselves from the 2020 study in the New England Journal that looked at, and this was the ischemia trial, deaths, the composite outcome of death from cardiovascular causes, MI, hospitalization, for patients who had a conservative strategy for their coronary artery disease and quite advanced coronary artery disease versus an invasive strategy. There was, at a 5-year period of time, no improvement in that cumulative incidence by getting PCIs done in patients who don't really need a PCI. So the guidelines from the UK say the cardiac CT is the first line investigation, and the guidelines are best based primarily on the diagnostic accuracy and cost effectiveness. In the European guidelines, they say you can use functional or stress tests or coronary CTAs in patients who you want to evaluate for obstructive coronary disease, but that coronary CTA should be considered as an alternative to invasive angiography if another non-invasive test is equivocal or non-diagnostic. Their studies show that doing the coronary CTA is the most cost-effective way of working up these patients rather than starting them off with a stress test or starting them off with an invasive cardiac cath. Of course, there are costs for the coronary CTA. This was created by one of my cardiology colleagues here at Hopkins, where you can see coronary CTAs are about $754 per test. The exercise treadmill much cheaper. The nuclear stress test actually more expensive. And the PET myocardial perfusion even more expensive than that. And in the right hands at places like Emory and Hopkins, you do not get a ton of radiation from your coronary CTA. It's about the same amount as background. In places that are not as used to doing them, the radiation will actually be significantly higher, but still less than getting a CT-PE protocol, which many of us do not bat an eye about getting. So not everyone should get a coronary CTA. This is not yet standard of care at all for patients who are having an ACS picture. Not the best test for patients who had previous cardiac catheterizations, particularly if they've gotten CABG or having a stent placed. And there are other things that you can read through here that make coronary CTA not applicable to all. So conclusions for this: order the coronary CTA, suggest ordering it in the DC summary instead of that stress test if you think someone needs to be worked up for obstructive disease. When you find that non-obstructive disease, make sure the patient's on the right preventive medications. Send patients for CABG will benefit them, and of course, don't do a PCI without a trial of medications. In my patient, the coronary CTAs found no obstructive coronary artery disease, and we just worked on aggressive risk factor management for her. She would have been in the mildly abnormal group, and we continued to treat her aggressively. All right. How about some things we do for no reasons that are consistent violations of evidence-based medicine, like using PPIs for ulcer prophylaxis on the ward, using people's race in their one-liner as you describe them, using steroids for anaphylaxis, treating non-suppurative cellulitis as a MRSA infection, using contact precautions, though I know that people will argue about this, emergent hemodialysis after contrast in end-stage renal patients, fluid restriction in heart failure, which folks will argue about too, but I think there is some reasonable data that that is probably a thing we do for no reason. And then certainly when the oxygen ferry comes by and puts on oxygen for patients who are not hypoxic, but are absolutely sure it makes them feel better. All right, so This is another violation of EBM. So your nurse calls and says that Mr. Montgomery Burns, who's a 71-year-old man with cellulitis, who has a history of hypertension and prior infarcts with PCI, is having elevated blood pressure. He doesn't have any end organ damage. He has no symptoms, but he has significantly elevated blood pressure. So just ask yourself, at what systolic blood pressure would you administer an as-needed antihypertensive? Because we have all been in this situation where the nurse calls and says the blood pressure is elevated. So what would it take for you to give some IV labetalol or something like that to this patient? 160 if their systolic blood pressure is 160. How about 180? They tell you that systolic blood pressure is 180. 200? Will that get you to do it? How about 220? Their systolic blood pressure is 220, but they're not having any symptoms. Do you want to give anything for that doctor? Or greater than 220? Or do you want to wait for their head or kidneys to explode? All right, so we all administer as needed antihypertensive for hypertensive urgency. And I think, of course, many of us are asking ourselves these days as to whether hypertensive urgency actually exists. I think we all agree there's a hypertensive emergency, but is there really an urgency? Well, certainly UpToDate defines urgency as greater than 180 systolic or 110 diastolic, and of course, no end organ damage. And the assumption then, urgent is an important word. We need to do something, because if I don't treat now, something bad will happen, like an acute stroke, MI, aortic dissection, hypertensive encephalopathy, pulmonary edema. Something bad is going to happen. And if it's urgent, it's going to happen soon, like over the next few days or hours. It's going to happen. So why treat? Well, we know that treating severe hypertension absolutely reduces the risk of those things that we just talked about. And UpToDate certainly tells us we should lower blood pressure over periods of hours to days rather than longer periods of time. And of course, if we call it urgency, the current standard of care suggests that we ought to treat. And we know that if we don't, we will keep getting paged about these blood pressures of 180 to 200 from the nurses, who are understandably getting nervous because we have created a culture where our nurses get nervous about a blood pressure of 180 and 200. So let's look at a couple studies to give us a sense about how worried we should be. So this was one of the first studies looking at treating blood pressure back in the 1960s. And this was a bunch of VA patients, 143 VA patients, who at that time, everybody was really worried about diastolic hypertension rather than systolic. We still thought systolic was probably pretty normal, but we thought maybe diastolic was not. So they looked at these VA patients who had diastolic blood pressures of 115 to 129. I think all of us would agree that's pretty elevated. And they started them on the blood pressure meds we used to give back then, the hydrochlorothiazides, the reserpines, or Hydral, or placebo, which clearly we could not get away with today. And at enrollment, their blood pressures in both groups were really high, 186 over 120. None of us want our patients to have blood pressures like that. In the treatment group, when they gave them those blood pressure meds, most of which we don't use anymore, their blood pressures actually came down. Their diastolics were now in the 90s. The placebo group, their blood pressure, their diastolic still remained very high in the 120s. And what you'll see is those who were treated had very few events, 1 stroke and 1 treatment complication, as compared to the placebo group that had many different bad outcomes. It was 40% of those in the placebo group, only 3% in the treatment group. So death, stroke, CHF, MI happened to 1 person in the treatment group and 14 in the placebo group. Treating blood pressure was really important. Number needed to treat for any event was 3. For death, stroke, CHF, MI was 5. Those are really good numbers needed to treat. We all would say, yes, treat that. But the number needed to treat was 3 and 5 at 1.5 years, not weeks. And in fact, the time to the first event in the active treatment group was 1 month. And in the placebo group was 2 months. It wasn't days, it wasn't weeks, it was a month in the active treatment group, the people who were actually getting meds. And in the placebo group where they got nothing, it was 2 months. And then we had the study in 2016 that came out of Cleveland Clinic, where they looked at all of their patients who showed up into their primary care clinics with what would be defined as hypertensive urgency, and then wanted to see what happened to those basically 60,000 patients. So how many of those 60,000 patients who showed up to the Cleveland Clinic primary care clinics with hypertensive urgency went to the ED? 0.7% of them. Right, of these people who came with a 180 over 110. They weren't being sent to the hospital to get their labetalol, or Hydral, or whatever you like to give IV. It was only 0.7% of them. And how many of those were admitted? 0.2% of the entire cohort. 100 patients out of those 60,000 patients who ended up getting admitted for hypertensive urgency. And so when you send home basically almost 60,000 patients with hypertensive urgency, how many of them have a major adverse cardiac event at 7 days? It's 1 in 1,000. For those who went to the hospital, it was 1 in 200. So someone knew something about those patients that made them think they were at higher risk. How about if 180 isn't enough, what happened to the patients with a greater than 200 systolic when they came to the clinics? Again, almost all of them were sent home, and only 1 in 500 of them had a MACE at 7 days, and none actually who were sent to the hospital. And how about greater than 220, which would, I think, scare the bejesus out of all of us? Most of them, again, went home. 1,000 patients, only 2 of them ended up having a major adverse cardiac event, 1 in 500, and again, 0 of them who were sent to the hospital. So adverse events from hypertensive urgency happen over weeks to months, not hours, while the patient is sitting in the hospital. And we have some studies, one out of UCSF, where they were trying to decrease the number of patients who were getting IV antihypertensives in the hospital. They were able to do that significantly without increasing their balancing measures of rapid response calls, ICU transfers, or code blue. And they did the same thing at Mount Sinai. Were able to decrease the number of patients who were getting IV antihypertensive medicines in the hospital, PRN, without having any adverse events. So you can do this. You can decrease the number of patients who get IV antihypertensives in the hospital without having bad events happen to those patients. So why might it be a bad idea to give patients as needed antihypertensives who have asymptomatic hypertensive urgency in the hospital? And I think all of us know, this is a study that looked at patients, it was 5 healthy men who were doing exercise, and they wanted to see, they put an A line in them to see how high their blood pressures would go while they were doing exercise. So at rest, their blood pressure was not exactly what we wanted, but at rest, it was 135 over 80. Then they started having them do curls, and the A line showed that their blood pressure went up to 240 over 160. Then they started doing leg presses, and their blood pressures in the A line went up to 325 over 245. And peak pressures went up to 480 over 350. Blood pressures can get pretty darn high without us dying from them right away. It does not mean we want our patients to have blood pressures of 325 over 245 for any significant period of time, but the body can deal with it for a short period of time. And then we have the study. This was a study that looked at patients with severe hypertension and what their brain circulation was like. And what this study ends up showing us is patients who have persistently elevated hypertension, they start having decreased blood flow to their brain when their MAPs get down to about 110, right? We worry about most patients at 65, but at these patients who had chronically elevated blood pressure, they started having reduced blood flow to their brain at a MAP of 110, as compared to the 65 or so that we're used to in patients who are normally hypertensive. For those patients who are have chronically elevated blood pressures, we don't want to decrease their MAP too quickly. We don't want to decrease the amount of blood flowing to their brain on a regular basis. So we know that there are adverse events associated with aggressive treatment of increased blood pressure, and that we can induce stroke by giving people nifedipine, rapidly active IV nifedipine, which no one is doing at all anymore. And we actually have the study out of JAMA Internal Medicine from 2020 that seemed to indicate that when we start treating blood pressure in the hospital, we get more AKIs and we get more myocardial injury in those patients who we treat than if we don't. I don't want to say I'm a nihilist, but I am very slow to treat blood pressure in the hospital. I don't think it reflects what their ambulatory blood pressure is like. Most people who are in the hospital have a blood pressure that's elevated, not because of whatever their underlying condition is, but because they're in the hospital at the time. And I think it is important to figure out when they're in the ambulatory setting, what their blood pressure really is running and not what it runs just in the hospital. So recommendations are, don't just do something, stand there, try to figure out why the patient's blood pressure is elevated. Or is it elevated because they have pain? Is it elevated because they're in alcohol withdrawal? What is it that's causing the elevation of their blood pressure? Don't just give them that labetalol or Hydral. You're probably better off thinking about the patient a lot more and watching them than giving medications. And then we need to help change the standard of care when it comes to this. So final consistent violation of EBM, docusate, giving patients docusate, I think is a consistent violation of EBM, which we do here at Johns Hopkins all the time. We give out a lot of docusate, and all of these studies show that docusate doesn't actually improve patients' bowel movements. It is not really a stool softener that makes a difference in their lives. We have one conclusion from the Goodman study: whether the drug actually offers anything beyond a placebo effect in preventing constipation is in doubt, although the issue of appropriate dosage must first be resolved. Clearly, 200 milligrams of docusate in addition to a regular diet offers no advantage over diet alone. Whether a greater dose offers any advantage remains to be determined. And we give out 45,000 of these 100 milligram docusates at Hopkins every year when it is a medication that does not have any data that it helps to prevent constipation or treat patients' constipation. And you will not find essentially in any GI recommendation or guideline to give docusate as a medication, yet we do it all the time. Finally, lots of laboratory studies that are things we do for no reason, whether it's prealbumin or tumor markers or urine lights for AKI workups or thrombophilia workups in the hospital or ammonia and chronic liver disease, lots of lab studies that are, and I can't take the inpatient vitamin D, lots of lab studies that we are doing that are things we do for no reason. So what do you do tomorrow? Don't order the coronary CTA or suggest ordering it in the hospital. Don't have them do the coronary CTA instead of that functional stress test. Don't treat hypertensive urgency reflexively, and don't prescribe docusate, please. Think about becoming a member of our providers for responsible ordering. You can take the Pro Pledge and join that group. What do you do over the next few months? Feel free to contact me to write a Things We Do for No Reason article for the Journal of Hospital Medicine. We would love to get your suggestions. Join if you are not involved, our High Value Practice Academic Alliance. There are over 100 partners now. It is a great group. We just had our annual meeting. It is a ton of fun to be able to share ways of providing high value care. And then what do you do over the next few years? Continue the great work I know you're doing at Emory on high value care, and add high value care to your QI agenda as you are working on it. So thank you all very much for having me today, and happy to answer a few questions with the remaining few minutes.
Thank you so much, Dr. Feldman. That was really interesting. I think if anybody has questions, you can type them into the chat. I think we have time for just a couple. It looks like Carrie as Benson says that Senna is an alternative to docusate if we want to do that.
Yes, and Senna is in the guidelines. Docusate is not.
And then repeating blood cultures is also something to think about, Susan Ray.
Yeah, those blood cultures, right. You get the blood culture when the patient's admitted because they were having fever. Then they have fever again in the hospital and you get another blood culture. And unless you are really worried about endocarditis, you are wasting your time getting more blood cultures. Totally agree.
Yeah. And she was saying also just for repeating for people who have like positive, like gram-negative bacteremia.
Yes, totally. Just treat it. You don't need to show that it cleared. Yes, love it.
And then let's see, Mohammed Musa, let's see, since our practice is based on the acquired behavior from training, what do you think about individual physician scorecards to improve cost-effective quality care?
So yeah, that's when I talked with our group of hospitalists earlier today, I was telling them that's one of the things we do here at Hopkins. We've done that with the residents. The residents didn't love it, but we are trying it again coming this winter. In January, they will start getting report cards. I think things that show where you stand compared to your colleagues on average are very helpful. And you know, all of us order too much, so the average is probably too high. But if you find that you are an outlier either way, then you're probably doing something a little bit out of the ordinary. And maybe if you're ordering a lot less, you're doing the right thing, but maybe you're not. So I think report cards are a great way of doing this. It is not as effective in the hierarchy of nudges of things that get people to practice high value care. It is up there, but it is not as effective as doing clinical decision support in your EMR that really pushes you to go the right way.
Yeah, and then we had a couple of comments in there too, but a question from Erica Heineman. It's hard to be an individual fighting against things we do for no reason. What are some system or state level actions that you would advocate for, like legislation showing prices of tests in the ordering clinician, ACGME regulations requiring more high value care training, something like that?
Yeah. So, right. I think it's all about shining a light. So report cards are about shining a light. We talked earlier today about the fact that in 1993, 50% of patients who were getting cataract surgery got some low value test before they got their cataract surgery. And in 2017, in a recent article out of the VA, 50% of patients who were going to get cataract surgery were still getting low value tests. If we had a report card that really showed to the government, to bodies in your state that you are ordering way too much of these low value tests, I think that would get us to change our habits, right? The hospital acquired conditions, people paid a lot of attention to the hospital acquired conditions when they were then associated with whether you were going to get paid or not. So when you are having to give data to people and then that affects your bottom line, that helps to spur on some changes. None of this is easy for sure, but yes, it needs to be system-wide. And man, wouldn't it be great if we weren't all doing this in Epic at each of our institution, but that Epic in Wisconsin was really able to help us. And so that we were all getting the same kind of interventions that have been shown to work.
Great. And then I have, let's see, just two more quick, I guess, question and comments. There's someone was saying there's so many potential targets for quality and waste. How would you prioritize, like where to start for folks?
So I think one of the things that we're doing here is using Agile MD. I don't know if you guys are using that at Emory, which is a really nice sort of algorithmic clinical decision support, which helps push providers in the right direction of ordering things. We've approached many of these low value practices as sort of one-offs. I think if you are just doing it as one-offs, that is really hard to make a dent. I think if you are using sort of these bigger guidelines that bundle them all together and point you in the right direction, you're going to have a much better chance of making a difference than if you're just trying to do one item at a time. So we've been successful at one item at a time, but in the big picture, that doesn't really affect how much our national healthcare expenditures are.
And then finally, one of the residents was asking if there is a things we do for no reason about the cardiac CTs.
No,
versus functional. No, there's not
no,
yet.
we haven't done it. We haven't written it up yet.
Good. Well, thank you so much again, and thanks for everyone who could join.
Thanks, Aaron. Thank you for having me. I really appreciate. I wish I could be there in person, but it's really nice to be able to interact with you guys today. And thank you for all the questions and comments.